Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
In this episode, we're going to be discussing intraoperative surgical complications and emergencies, including their identification and management. Our learning objectives are to acknowledge that intraoperative complications are less common than postoperative complications, to recognize that both mental and emotional preparation and technical knowledge are important components of managing intraoperative complications, to review the identification and management of the most common and/or serious vascular, urologic, and GI injuries, and to discuss the rare complication of pancreatic tail injuries and an alternative approach to splenectomies.
Great. I'll start us off. This is a shorty but a goodie. Before we dive deep into this episode, we want to encourage everyone to take a deep breath, as we know this topic can bring up some unpleasant thoughts. We've all heard the saying, if you operate enough, you will have complications. These are inevitable, so preparation is the most important step. Preparation pertains both to mental and emotional regulation, as well as technical knowledge. Before a complication is actively occurring, thoughtfully consider how you would manage it yourself if you were the one in charge. Rehearse mentally about how you would act and respond, and which people or equipment you would ask for. What's the worst thing that could happen here, and how would I handle it? Checklists can be helpful in the moment, as decision-making at critical times can be difficult and clouded by emotion. Remember as the primary surgeon that you are the captain. You set the tone for the circulators, anesthesia team, and trainees. Consider adding length of surgery and expected blood loss, including when the high EBL portions of the procedure will occur, to your surgical timeout to clarify expectations and increase team cohesiveness. A thoughtful pre-op setup is a setup for success. For open surgery, ensure adequate assistant, lighting, and retraction. Consider a low lithotomy position and confirm excellent IV access. For laparoscopic surgery, having an assistant port that's 8 millimeters or greater to pass Ratex and suture, a suction irrigator, and a clip applier available can be critical. With those principles in mind, Maya, want to begin our discussion on vascular injuries?
Certainly. There are minor vascular injuries, major vascular injuries, and diffuse or generalized bleeding events like coagulopathies. Always, the first step is to control with pressure, a finger, a sponge stick, or a pack. While you or your assistant is holding pressure, optimize your lighting, retraction, exposure, and suction. Consider setting up a second suction if necessary. Give your support staff a moment to gather the supplies you'll need for repair and call for help if you need it. Ask your anesthesia colleagues if they need a moment to catch up with blood products. Arterial injuries are relatively rare. Intimal injuries may occur in patients with underlying atherosclerosis. Make sure to monitor distal perfusion closely to rule out embolic events. In the event of an arterial puncture or tear, hold pressure as stated, and then obtain control proximally and distally. This may require aortic compression or vascular clamps. Small arterial defects can often be repaired with a fine monofilament suture, such as 4-O-proline, to reduce the coefficient of friction. But larger defects may require vascular surgery consultation for arterial grafting. The inferior epigastric artery is a classic site of injury during laparoscopic entry. One can use either a Foley balloon placed through the trocar with applied upward traction or a balloon trocar for occlusion of the entry. Then identify the proximal and distal portions of the vessel that are injured and tie it off either laparoscopically or with a Carter-Thomason device or something similar.
Venous injuries are more common. For small veins, occlude with a finger, then slowly roll off the vein while suctioning and secure the defect with a pickup. You can apply a clip below, but make sure to avoid pulling as you may tear the vein even more. Larger veins, such as the external iliac or hypogastric, require additional exposure. Use Judd Alice clamps to show yourself the injury, then clip it if there's a vascular stump remaining, or suture the defect as needed. The largest veins, such as the vena cava, use similar principles, although you may need an intervening pledget, which is a small piece of non-absorbable material such as felt or PTFE used to reinforce sutures. If the defect is too large, call in vascular, who may need to patch the defect with autologous vein, bovine pericardium, or synthetic materials. You can also consider preemptively placing POTS ties or ligatures proximally and distally to the area of dissection by passing a vessel loop circumferentially around the vessel and applying traction to collapse the vessel and restrict blood flow. Lastly, presacral veins present a unique situation in which the vein may retract into the sacral foramen, precluding the ability to grasp or see the defect. In these cases, you can use packing or tacking techniques, topical hemostatic agents, or direct or indirect electrocoagulation and suture. Some unique management options include insertion of a sterile thumbtack into the sacral foramen, application of bone cement or wax, or high wattage diathermy up to 100 watts to weld a fragment of omentum or rectus to achieve hemostasis. What about ongoing pelvic bleeding? Then what?
If you have diffuse bleeding, assess for and correct any coagulopathy. Most massive transfusion protocols aim for balanced resuscitation in a 1:1:1 ratio of packed red blood cells, fresh frozen plasma, and platelets. Consider point-of-care testing with thromboelastography, TEG, or rotational thromboelastometry, ROTEM, for tailored resuscitation if available. These technologies work by measuring how a blood clot develops, stiffens, and breaks down, and the graphical outputs can be interpreted to determine which blood products are needed. Maintain normothermia, as hypothermia leads to impaired platelet function. Prevent hypocalcemia and hyperkalemia during the process. Assess for acid-base status and correct acidosis. One can also perform an intraoperative hypogastric artery ligation by tracing back to the anterior division of the internal iliac artery from the obliterated umbilical ligament. Classical teaching is that the artery should be ligated 2 to 3 centimeters distal to the bifurcation of the common iliac to avoid ligation of the posterior division of the internal iliac artery. Ongoing venous oozing can be controlled with hemostatic agents like gel foam, Surgicel, FlowSeal, Arista, or Everest. If your patient is hemodynamically stable, consider unilateral or bilateral uterine artery embolization with IR if applicable. But know that this process can take 30 minutes or more to get set up and going. Lastly, if all of the above interventions fail, pack the abdomen and perform a take-back procedure when the patient is stabilized, usually in about 48 hours.
Thanks for that review. Next up, we're going to talk about gastrointestinal injuries. These can occur during dissection or during entry. Closing a bowel injury depends on several factors, including the location, extent of the injury, patient stability, degree of contamination, and time since injury. A key principle in bowel repair is suture orientation. Always close the defect perpendicular to the long axis of the bowel to minimize stricture risk. An easy way to remember this: throw your suture in the line the stool travels. First up is small bowel injuries. For a simple laceration that's less than 50% of the circumference with minimal devitalization, a primary repair in 2 layers can be performed. The inner layer should be done with an absorbable suture such as 2 or 3 vicryl with full thickness continuous or interrupted throws. The outer layer should be performed with Limbert or interrupted throws through the seromuscular layers with absorbable or non-absorbable suture such as 2 or 3 silk. For Limbert stitches, the suture is placed in a way that the stitches are perpendicular to the tissue edges, typically with the needle entering and exiting the tissue at the opposite sides of the incision, creating a series of folds in the tissue, helping to seal the edges securely. If there's an injury greater than 50% of the circumference or devitalized tissue, then a segmental resection and primary anastomosis, either end-to-end or side-to-side, should be performed. While we acknowledge some of you are familiar with bowel resections and reanastomoses, there are others who may not be. We'll take just a moment to describe the technique here. First, mobilize and isolate the injured segment. Divide the mesentery to preserve adequate blood flow to the bowel ends and ensure hemostasis at the mesenteric border. Fire a linear stapler proximally and distally to the injury. Align the healthy bowels side by side at the antimesenteric borders and make enterotomies. Then insert a linear stapler into each bowel loop and fire it to create a common lumen. Use of a GIA or TA stapler across the common enterotomy to close the common lumen is based on surgeon preference. Side-to-side anastomoses are preferred in a edematous or thick-walled bowel. Now, large bowel injuries are managed differently depending on the clinical context. For small injuries, especially in healthy, non-contaminated colon, primary repair can be considered. In stable patients with a larger defect that is clean or minimally contaminated, segmental resection with primary anastomosis can be used. Colonic resection and diversion with either an end colostomy or loop colostomy should be used when patients are unstable, there's gross contamination, or there's a delayed presentation. Thermal injury can be a bit more complicated. It can be caused by direct contact, conductive heat, capacitive coupling, or insulation failure. Intraoperative clues for thermal bowel injury include discoloration or charring on the serosa, edematous or blistered tissue, and bowel that seems sluggish or non-viable despite intact blood flow. It's important to recognize that most thermal injuries don't penetrate the full thickness at first, but can progress post-op due to thermal necrosis, leading to delayed perforation or peritonitis. If the injury is recognized intra-op and is a small superficial burn, one can consider local excision and primary repair. However, if it is full thickness or of questionable viability, go ahead and resect the segment. 1 to 2 centimeters on either side of the visible injury is a good rule of thumb, using the principles described above. Maya, can you give us a crash course on surgical staplers?
For sure. Staplers come with two numerical descriptors, both the length of the staple line and the depth of the staples themselves, or the staple legs. The most common staple depths would be 2 to 2.5 millimeters for vascular pedicles or potentially small bowel, 4.8 millimeters for large bowel, 3.5 or 3.8 millimeter staples can be used for thicker small bowel, sometimes for large bowel or early edema in the small bowel. Each of these depths is aimed to balance the risk of ischemia with the risk of leak in each respective tissue. The staple line length is determined by the amount of tissue that you're stapling and the width or length that you need to cover. As mentioned previously, there's different types of staplers, and you should be familiar with each. GIA, endo-GIA, and TA staplers are linear staplers. GIA and endo-GIA have two double rows of staples with a central knife that divides the tissue. These are used for side-to-side anastomoses. TA staplers have 1 or 2 rows of staples without a cutting element. They're often used to close enterotomies or gastrostomies, or they can be used to reinforce staple lines. They're also commonly used to divide the rectum from the sigmoid colon in the deep pelvis. There's a contour stapler, which has a curve that fits into the pelvis, and that can also be used to divide the rectum from the sigmoid colon. EEA, which stands for end-to-end anastomosis staplers, are circular staplers, which create an anastomosis between two bowel ends. The anvil is placed in one bowel end, typically the sigmoid or descending colon, and the stapler is inserted into the other end, typically through the anus and into the rectum. When fired, it creates a resection of two donuts, which are small tissue circles around a circular staple line. You can confirm anastomotic integrity with a bubble test by filling the pelvis with fluid and injecting air into the rectum with a proctoscope. Ensuring that you have 2 complete donuts of tissue is another helpful way to confirm that the anastomosis was robust and there was enough tissue included.
Thanks, that's helpful. Let's shift gears to urologic injuries. The most commonly injured structures are the bladder and ureters, and less commonly the urethra. Benign pathologies such as large fibroids or endometriosis, advanced malignancy with distortion of normal anatomy, and prior radiation or pelvic surgery can increase the risk. Start with prevention. Know your landmarks. The ureter crosses the pelvic brim at the bifurcation of the common iliac artery, travels medial to the internal iliac artery along the medial leaf of the broad ligament, and passes underneath the uterine artery about 1.5 to 2 centimeters lateral to the cervix. Ureteral injuries are high risk because they're often not identified intraoperatively. If you do recognize a ureteral injury intraoperatively, location is everything. Identification of these injuries is most reliable with direct visualization, but cystoscopy and ureteral stenting can help to identify and characterize the lesion. Preoperative stenting does not reduce the risk of injury or prevent ureteral injuries. However, some suggest it can help identify a ureteral injury incurred with difficult dissections. Some injuries, such as crush, kink, or suture injury, can be managed by stenting alone. Transections or thermal injuries, if identified intraoperatively, are best managed by possible resection and primary repair. Ureteral injuries most often occur in the distal third of the ureter, with the most common location at the level of the uterine artery. For injuries within 6 centimeters of the bladder, then reimplantation with ureteroneocystotomy is preferred. A psoas hitch can be performed to make the reanastomosis tension-free. In this procedure, an incision is made into the bladder is retracted cranially and attached to the psoas muscle, and the ureter is reimplanted into the bladder dome. If there's an injury in the middle 1/3, consider a Boari flap. To do this, strip a flap of tissue from the bladder dome, tubularize it, and reanastomose it with the ureter. If there's a clean transection, a short segment injury, or it's further than 7 centimeters from the bladder, you can consider a ureterosterotomy. In this case, spatulate both ends using pot scissors and oppose the ureters with interrupted absorbable sutures. A stent should be placed during the healing process to prevent stricture. Stents are selected based on the patient's height. Individuals between 165 to 175 centimeters usually require a 26 centimeter stent, with taller people requiring a 28 centimeter stent and shorter people a 24 centimeter. These stents will need to stay in place for several weeks, and a CT urogram is recommended to confirm resolution of injury. What about bladder and urethral injuries?
Most bladder injuries occur at the dome of the bladder, often during initial abdominal wall entry when incising the peritoneum, sometimes during adhesiolysis of a deeply scarred pelvis, can happen during dissection within the retropubic space or the space of Retzius, or with peritoneal stripping. If you suspect a bladder injury because you saw urine in the field or your dissection went suspiciously deep, or if you see a Foley catheter, stop and evaluate. Retrograde installation of fluid can be used to confirm. Repair during primary surgery decreases the risk of fistula formation later on. And so ideally, we identify the full length of the defect and repair it at the same time. If you're unsure whether the trigone or ureteral orifices are involved, open the dome defect further and look. It's better to know for sure than to miss a more complex injury, and the dome is more resilient in the face of an injury than the trigone. Repair is relatively simple. Defects more than 1 centimeter require a 2-layer closure. First, you reapproximate the mucosa and muscularis with an absorbable suture like a 3/0 Vicryl. Then do a second imbricating layer to make the closure watertight. Leave a Foley for continuous bladder drainage. 5 to 7 days is standard, and the bladder should regain its normal strength after about 21 days. If the trigone is involved, you should be more cautious. Need to identify both ureteral orifices and repair with the same 2-layer closure, making sure to avoid distorting the ureters or the ureteral orifices and sewing in a direction away from the ureteral orifices. If there's any concern for tension or kinking at the orifices, you should place ureteral stents. And you could consider doing this prior to your repair if you're extra worried. If the stents are staying in place postoperatively, they'll often stay in for 4 to 6 weeks, and you'll still continue Foley catheter drainage for 5 to 7 days. Urethral injuries are the most rare and often present postoperatively with urinary retention or incontinence. The most common cause is from a radical vulvar resection. The distal 1/3 of the urethra can be resected without losing continence, as this is distal to the sphincter urethrae muscle. If more proximal injury is noted, this can be closed primarily off tension, and a Foley should be maintained for 5 to 7 days. Sydney, let's take a left turn to something that we don't see as often, but that can be serious: pancreatic tail injuries. Would you review for us?
Of course. Pancreatic tail injuries are rare but can be devastating when they occur. The pancreatic tail lies in the left upper quadrant, nestled in the splenorenal ligament, directly caudal to the splenic artery and vein. Tail injuries most often occur when operating near the splenic flexure or on the spleen itself. However, the key to managing pancreatic tail injuries is early recognition and controlled repair to prevent both hemorrhage and the risk of pancreatic fistulas or abscesses down the road. This can be tricky though. If there's unexpected bleeding, hematoma, or pancreatic fluid in the field, stop and assess. For small pancreatic tail tears, simple direct closure with fine absorbable suture like 4-0 or 5-0 Vicryl may be sufficient. For more extensive injuries, especially those involving the splenic vessels, you may need to perform splenectomy, pancreatic tail resection, or pancreatic duct stenting. Remember, it's okay to call a consultant if needed. There are two approaches to splenectomies, the anterior and lateral approaches. The anterior approach is the more traditional method, and the lateral approach is an alternative technique that provides a more direct angle to the spleen. The risk of pancreatic tail injury may be lower with the lateral approach.
Thanks for the review. That's all we have for you today, and we hope you learned something on today's episode of Ready, Set, GYO. Here are your key takeaways. Intraoperative complications are less common than postoperative complications. As a general principle, identification and management of an operative injury at the time of surgery leads to better outcomes than recognition and diagnosis of the complication postoperatively.
Preparation is crucial for optimal management of an intraoperative complication. It's important to practice for these rare outcomes by thinking through all the steps of a procedure outside of the OR, from positioning to staff or equipment availability. Consider checklists and mentally rehearse how you might respond in the moment.
The key to managing intraoperative vascular injuries lies in a methodical approach that combines immediate control with pressure, careful assessment, and collaboration with the surgical and anesthesia teams. Properly addressing arterial and venous injuries, correcting coagulopathies, and utilizing hemostatic agents can help stabilize the patient and guide further interventions if necessary.
Managing gastrointestinal injuries involves a clinical assessment of the injury's size, location, type, like thermal versus cold cut, and timing, as well as the patient's overall condition. Simple small bowel injuries that are less than 50% of the circumference can typically be repaired with sutures, while more extensive damage may require resection and reanastomosis. For large bowel injuries, the approach is similar. It's important to be familiar with your types of staplers, as well as which depth of staple is indicated for each tissue.
A solid understanding of key anatomical landmarks is essential to prevent urologic injuries, especially when dealing with the ureters. Ureteral injuries can be treated using techniques such as a psoas hitch or a Bowery flap, depending on the injury's location, while bladder injuries typically require a 2-layer closure with extended decompression.
Pancreatic tail injuries, though rare, require prompt recognition and controlled repair to prevent complications like hemorrhage and fistulas, with minor injuries treated by simple closure and severe cases needing resection, splenectomy, or duct stenting. The lateral approach for splenectomy offers better access and may decrease the risk of fistula overall.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at Ready, Set, GYO.
To support us and our production of future episodes, check out our Patreon at Ready, Set, GYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editors are Brogan Brown and Kylie Knight.
Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Justin Harrell, faculty at the Medical University of South Carolina, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.